professional development by the North Carolina Nurses Association and accredited approver by American Nurses Credentialing Center's Commission on Accreditation. At the completion of our session, we will drop in a link for those that are interested in actually receiving contact hours, and you can click that link to continue on. We look forward to having you here. And so our session today is understanding the trauma of perinatal loss of patients and providers. And we've had the opportunity to work with Dr. Johnson over the past few years. And so we're excited to have her share more about her work. And I'll turn it over to Dr. Johnson.
Okay, I am gonna attempt to do this so I can see my notes and y'all see it. What are y'all saying?
It looks great.
Perfect. Okay. Just as we're getting started, one thing I always like to say at the beginning of this presentation is that I know I have a decent amount of content. I want to make sure I stick to the time requirements. If there's particular things that you're like, I really want to make sure that my question get answered, please throw it in the chat. If there are particular topics that you have, please throw it in the chat and I'll make sure I can try to get to it during our 30 or so minutes together. Just to introduce myself, so I am a licensed counseling psychologist. I work primarily in women's health, so primarily with perinatal mental health. I worked in fertility clinics, NICU, OBGYN office. And one of the reasons I got into this work is I worked in the NICU for a year during my training, and there was a lot of loss. And one of the things that came up was, how do you support parents through this? And I remember looking in the literature and realizing that the folks who are most affected by it were the people who are least researched. So that kind of led me to kind of really ask more questions about kind of what's going on and how do I look at perinatal loss? How do we look at it as a society? So today I really want to go an overview of perinatal loss, look at how perinatal loss in the United States within North Carolina specifically, look at share a little bit from my own research and research out there, and then kind of get into the practicality, like how do we actually support families? What does that look like? How do we also manage our own grief? One of the quotes that I like to center ourselves as we have this discussion is there is so much more to a woman than her pregnancy. They need to understand our eating, our living situation, our support system, our mental and physical health. It makes a whole difference. Look at the whole me. Now, this is coming from actually a really great mixed method study on Black infant mortality. And this is one of the participants speaking about what they want other folks to know about their experience. So when we look at perinatal loss in the United States, as you can see, the numbers aren't looking good.
She answered, hi.
Okay, so the numbers are not looking good. So we look at like fetal mortality, and by fetal mortality, these statistics are looking at any death, fetal loss occurring at any point of the gestational age. And so really when you're looking at Black women, you can see by these numbers that they are at likely twice as much, affected is twice as high than other women of other ethnic groups, excluding Native Hawaiian and other Pacific Islander. When we zoom down into miscarriages, Black women are also 1.5 times more likely to experience a miscarriage than white women. When we think about, there's a lot of factors that coming into the play that are driving these numbers and driving statistics. One thing to think about is experiences of racism and how that studies have shown it negatively affects pregnancy and birth outcome among Black women. Studies have also shown that racial concordance between providers and patients, so Black doctors working with Black infants, there's some new studies out there looking at how that is actually protective. And so all of these things are shaping how perinatal loss is looking like in the United States. Even more interesting is that bereaved African Americans were less likely to receive psychiatric and emotional support through their lives. When we zoom into the North Carolina, the numbers don't look better. So when we're looking at Black women with late fetal mortality, and that's really after loss after 28 weeks, you're seeing that it's again twice as likely, twice as high. When we're looking at infant mortality, again, it's twice as high looking at other ethnic groups except for American Indian, Alaskan Native. And so when you're looking at these statistics, like what do they mean? So the national average, the average of infant mortality in North Carolina was 6.8 in 2019. That averaged to about 800 infants who died within the first year. So when we look at these numbers and what do they mean when comparing the North Carolina statistics to the United States, it's a lot of health inequities. And when we think about what is driving this inequities, that's kind of where I'm trying to get into with my research, and how does that affect the folks who are experiencing these things. And some of the leading causes of death as well were birth defects, premature, low birth weight, sudden infant death syndrome, as well as complications of pregnancy. Let's zoom in just a little bit more. I know this slide is a little bit hard to see, but when you're looking at the counties, they did this thing called disparity ratios. And by disparity ratios, what it means is that, that they looked at the rates of infant mortality across the different counties, and they divided it for Black infants and for white infants. And when they came up with this ratio to really look at what is the disparity, how egregious is it, than just looking at the rate themselves. So when we zoom into the counties that surround us, the counties that with a lot of the patients that we work with, at least closer to Durham, we can see that the counties that are most affected are like Caswell, Person, where there is like a large disparity between Black infants dying and white infants. These health inequities also show up with maternal mortality. When we look at the rates of women who are dying, it's disproportionately women of color. And we think of that things that like education and age are non-protective factors. For Black women, they are 5 times as high as white women with a college degree. When you think about what that really looks like, it's about 700 women each year from the latest statistics. And that's about 2 to 3 times more American Indian and Black women are more likely to die from pregnancy-related causes. And you can see that this rate also increases with age for Black women. When we're looking in North Carolina specifically, again, the disparities are high. And what's kind of really saddening is that the disparity has been shrinking, that gap between white women and Black women who die with pregnancy, but it's not because less Black women are dying, it's because more white women are dying. And when we look at why these things are happening, there's actually something really cool called the North Carolina Maternal Mortality Review Committee. And it's something I would really look at, that you can join that committee and be a part of the process, but they review death records, and they look at cases of maternal mortality across the state, and they meet on a periodic basis. And one of the things they found was that 70% of these deaths were preventable. By preventable, they meant that they were caused by like hemorrhaging, infection, other aspects that could have been better managed. So the reason I go through all the statistics is really just to understand, okay, this is what's shaping perinatal loss. This is what's shaping the patients that we're working with, and really should guide this discussion of why it's important to look at this topic and why it's something that we need to really considering when looking at patient care. So as I go through, I always like to pause and just make sure I'm defining, we all have the same definitions for things. So when we think about how I define perinatal loss, when we think about miscarriages, as y'all know, is 20 weeks or less. The literature can sometimes shift. With stillbirths, it's sometimes at 20 weeks or more. Sometimes it's even later. But infant mortality was in the first year, neonatal deaths within the first 28 days of life, and the NICU and PICU death are really just signifying when the death occurred. When thinking about more moving past just like the physical aspects of what's happening in the body of the birthing person, it's really the emotional and psychological. Perinatal loss, I love this quote, includes the loss of the creation of life. It's more than this physical aspect. It's about our hopes or the dreams of the parent. It's what we planned for, what we thought was going to happen, and that shattering before their eyes. When you think about how it's so impactful, before the life comes, there's a lot of buildup. If we think about our own pregnancy experiences or pregnancy experience of loved ones, you know that there is, even for unplanned pregnancies, there's a lot of thoughts of what's going to happen after the pregnancy. What am I going to be like as a parent? What are my dreams, hopes, and for my unborn child? There's all the celebrations we do depending upon our culture, from the gender reveals to the baby showers. All of those are building into identity development. It's building into what we think is going to happen, our expectations of parenthood. There's also the logistics, like you got to tell your job, you got to build your nursery, you got to plan for your unborn child. All of those pieces are coming into play and playing into the identity development of what it means to become a parent. So imagine as that buildup happens, then this loss occurs. And that is a significant traumatic event in the lives of parents. The emotional responses run the gamut. It's anything from guilt to self-blame to anger to suicidal ideation to depression, regret. A lot of patients will come in with the woulda, shoulda, coulda. the what of like, what if I had done this? And what if I had said this to my doctor? What if I had asked for this? Or I knew this was going to happen. And people will rack their brain of all the things they could have done to prevent this loss. There are also all of these physiological components. Depending on when the loss occurred, you could still be lactating. There's still the hormonal changes. Even when a woman goes through, or birthing person goes through a loss, they're still having this on hormonal responses. Their body is still going through it. It can take a long time for your body to feel normal again. A lot of folks will talk about, my body failed. Something's wrong with me, that I couldn't do this thing that everyone else can do. Everyone else seemed to do easily, right? And then there's also idea of like, when we think about how we view women in our society, what does it mean to be a woman? What does it mean to be a woman who is not able to carry a child to term, or not able to lose a child within the first years of life? And how does that change how I view myself? So all of these things come into play when we're thinking about how loss affects families. The other thing is, when thinking about the consequences of grief, is really this thing called disenfranchised grief. So it's that idea that our grief isn't really grief. A lot of times the patients will come in and they'll be like, if it's a miscarriage, people are like, oh, you should be getting over that by now. There's a timestamp on how long they should be grieving, or it's not that bad because the child wasn't living this long. That all comes into play. Or folks are met with silence. We know that adage of, if you don't have anything nice to say, don't say anything at all. And some folks will say that I told my family that I had this miscarriage, this stillbirth, this infant death, and folks just don't know what to say. So they just don't say anything. So it can be a very isolating experience. And then also when you zoom out, a lot of times when folks are pregnant, a lot of their same age peers are also getting pregnant at the same time. So there can be this disconnect from my friend group if everyone else has children and I do not. What does that say about me? Also, when we think about loss and grief, there's a script, right? When someone passes away, especially someone who's older, we have this script of, we go through their things, we talk about memories, we have pictures, we have photos. That just doesn't occur with perinatal loss. There's not always a lot of concrete mementos, right? We may not even go through the rituals in our culture, whether it's a funeral or memorial service. That doesn't always occur with this type of loss and this type of grief. And so that all plays into, how do I mourn and how do I cope with it?
Yesterday.
There's oftentimes differences even between partners, right? A lot of the literature is on heterosexual partners, and they'll show that women are more emotive, they're more expressive, the grief is much more apparent. For fathers, it's just, there's a lot more disconnect, they're more reserved with their grief. And even in my experience between families of diverse family, is that the person who is the birthing person is really feeling it, they're feeling the physical effects of it, it can be very visceral. For the other person, all of their energy usually goes to supporting their partner. I don't have time to grieve. I got to work. I got to keep the house lights on. So their grief is quieted. And it can become this discordance where, do you really care? Do you not experience what I'm experiencing? And this disconnect often occurs. I also get this question a lot. Like, shouldn't it be that the further along the pregnancy, the more intense the grief? The research actually is mixed. So whether it's a miscarriage or stillbirth, some studies will show that that is true, that your grief is more intense if the pregnancy or the loss occurs later on. Other studies show that it can be intense no matter where it occurs. The other piece of it is that often along with this fertility journey, folks can have multiple losses or different types of losses, and there can be this cumulative effect. Or they can have other losses in addition to the perinatal loss, where some folks will be like, I lost my mom, and then this happened, and I lost my grandfather, I lost someone else. And it's all that cumulative total shows how the toll is taking on them emotionally and physically. When we think about the consequences of perinatal loss, research shows that it's traumatic stress symptoms. Folks will have PTSD level symptoms where they're having intrusive memories, they're having flashbacks, they're having avoidance, they can't go back to the hospital, they can't be around small children. It's that intense for them. There's also depression as well as anxiety. Interestingly, one study looked at parents of children who died in the PICU and NICU. They found that there was more hospitalizations for the parent, more chronic illness for the parent. So not only is it this emotional, psychological toll, it can take a toll on our physical well-being. In addition to just kind of these other negative consequences, there's also this idea of post-traumatic growth. So after we go through a trauma, we change. Some folks will change the way they go through their relationships, their spirituality. It changes the way they see the world. this bad thing happened. And in a just world, when good things happen to good people and this bad thing happens and I can't wrap my head around it, now I have to reconfigure how I see the world. My worldview changes. So that also kind of occurs as well. When thinking about models of grief, we all typically know the stage model of bargaining, acceptance, there's anger, there's denial. And I usually don't love, even though there's a lot of evidence for that model. Stage models kind of say you start in one place and you end in another. The way I like to look at grief and I show is I use a dual process model of grief. And so in this model, there's two buckets. We have the loss-oriented and restoration-oriented. So loss-oriented is what we know. That's the throes of grief. That's intrusive feelings of grief, the memories that are coming back. You're crying all of a sudden. It's really hard to get going and to start the new chapter after this loss has occurred. Then you have the restoration-oriented, where I'm attending to the new changes. I'm doing new things. I'm figuring out who I am after this loss. And a lot of folks will come into my office and they're thinking like, I'm here, Ashley, and I want to get here. And that's usually not how it goes. It's like we actually kind of bounce back and forth. We're vacillating. And that's the grief work, where some days you may be in it and it's intense and it's hard. And other days you might be feeling like you're moving on and you're okay. And it's going back and forth. Sometimes I like to use the metaphor of waves, where like we are in waves of grief, where sometimes the wave is big, sometimes the wave is small, but it's hitting you all the same. When we think about pregnancy after loss, a lot of folks will say, and the literature shows that it's intense anxiety and fear, that they kind of are held hostage during this next pregnancy after having a loss. For a lot of folks, it's really hard until they get past the milestone. So if they lost their baby at 8 weeks, they're trying to get there. And it can be very anxiety provoking those first few 8 weeks. They can also be this loss of hypervigilance. I am scanning my body at all times. I'm trying to be like, if I don't feel a kick count, if I don't feel this happening, what does that mean? Am I losing the baby again? I remember one patient who had trouble going to the bathroom because she lost her pregnancy in the bathroom. So going to the bathroom was this really acute response. It was really distressing. It also could be like reliving the trauma. Like your body, like because it's something that happens to your body, that anything that else happens to your body can be triggering. It can be bringing back these sense of trauma, these things of loss that's occurring. And when you think about birth trauma itself, oftentimes in our society, we paint birth and delivery as this magical, amazing experience. And for some women it is. And for other women, it's not. It can be this traumatic experience that leaves them with acute traumatic stress disorder or PTSD. And some contributing factors, if they had perinatal mood issues before, if there's pregnancy complications or a history of PTSD and trauma in their lives before the birth continues. But when you think about birth trauma and how we define it, it's an event occurring during labor or birth that's an actual or threatened injury of death to the mother or the infant, in which the birthing person feels intense fear, helplessness, loss of control, or horror. The literature calls it a loss of dignity, that even if everything goes okay, even if everyone comes out alive and safe, but my dignity and my voice was stolen from me. I didn't know what was happening. I wasn't able to have agency of what was happening to my body. It can be traumatic. And when we think about how that plays out, this picture is hard to see, but the roots are that lack of communication, lack of control, helplessness, powerlessness, or the loss actually occurring, or even a threatening of their own mental and physical safety. And then what we see with the branches is this is the shame, this is the PTSD, this is the panic attack, this is where I'm zoning out, I'm having nightmares, flashbacks. And so it's all this tree of trauma, right? And a big piece of this is that when there's just disconnect in communication between the patient and provider, that increases the likelihood of birth trauma occurring. So all this leads up into some of the research I've done. So again, because Black women were disproportionately affected by perinatal loss, I really wanted to understand, what is their grieving experience? How do they grieve? How do they cope? And I wanted to give voice to their struggle. So I did both a qualitative and quantitative study. So I looked at both measure findings, and I just gave participants space to just tell me their story and tell me how they were coping. So what a lot of the study findings was that it confirmed earlier studies of Black perinatal grief. It is intense. They grieve, like there's intense grief, there's depression symptoms, but they're also post-traumatic growth, and that folks said they changed coming out of this grieving experience. I also looked at the role of spirituality and cultural coping strategies like strength schemas and how we try to be strong to get through things and try to be strong to cope. One of the things that I found that spirituality wasn't good nor bad, that some people leaned on their faith to get through this trauma. Other people struggled and grappled with their faith. Also, what does it mean to be strong and also go through something so traumatic? So some of the clinical implications was really looking at an intersectional approach, looking at all aspects of their identity, all aspects of their experience, and using that to guide treatment and healing. Also providing space to talk about some of the hard things and their grappling. If there's a struggle with their faith, providing space for that, because oftentimes there may not be space in other areas of their life. The qualitative portion, I kind of broken into themes. So one thing that came out, it was experience in the healthcare, feeling invalidated, ignored, and misdiagnosed. A lot of folks said that how their race and their gender impacted their care they received, their experience, how they saw themselves, how folks saw them. People said that they felt misheard, disrespected. I still get shocked when people tell me what folks will say in the wake of their loss, sometimes by providers, sometimes by friends and family, and the insensitivity of the comments, even the ones that are well-intentioned. Some folks will just say they felt invisible and no one saw them, no one saw their pain, no one saw their struggle. There was also themes of discrimination and mistrust. So like I felt discriminated against because of my insurance coverage, because of race, because of gender. And because of that, I don't trust doctors now. I don't trust them. I don't want to go back to doctors. It's really hard for me to trust the healthcare providers. There was also this theme of treating me as just a body. Like I don't have emotions. I'm not suffering emotionally and psychologically from this loss. So this hyper focus on the medical aspects, the physical aspects of the loss, and just feeling like folks were responding to them in a sterile or detached or cold manner. But there was instances of compassionate care. Folks also talked about how they had nurses and OBGYNs and doctors who went above and beyond, who provided resources for their psychological and social support. They were supportive in their actions. They really cared for the family and wrapped their arms around the family. Some said it was a mixed bag, that it wasn't wholly positive, it wasn't wholly negative, and that they had some negative experiences and some positive ones. One thing that struck me is how many people encounter, especially if their loss is occurring in a hospital setting, from the front desk, the ED doctors, to the OBGYN inpatient, to the nurses on patient, and each person has the potential to have a really compassionate experience or not a compassionate experience for folks. And people also, even though I didn't directly ask, provided their feedback and said, these are the things that we want. We want better resources. We want more mental health resources offered at the onset, that resources that are tailored to my experience, that are really focused for Black women. Some folks said that they had some mental health supports, but when they looked around the room, nobody looked like them, and how that was really important to feel connected. They talked about wanting their providers to be empathetic, to show empathy, to show that emotion, show that compassionate care. And also there was the logistic considerations that even if the care they provide was compassionate, was great and valued, that the fact that they had to sit in a waiting room after their loss with the other pregnant women was excruciating for some folks. And those kind of like logistical things that we do, and how do we set up our offices, how do we set up our waiting rooms to really care for these folks. So really, when thinking about practical strategies, so what can we do to support families? So I'm gonna pause for a moment. So why is loss, particularly miscarriage, stillbirth, infant death, so hard to talk about in our society? And I'm gonna try to like look in the chat real quick. And so folks can just throw in the chat, like, why might it be so hard to talk about? What might be things that are coming up?
Can you repeat the question one more time?
Sure. Why might it be really hard to support families? Why is it hard to know what to say?
Oh, yeah.
Yeah, people can be scared to say the wrong thing. People don't know what to say. We heard that again. You don't have nothing nice to say, don't say nothing. That's what we're taught, right? It comes off as nosy, it's uncomfortable, fear. Yes, all of those things, right? And it might be reminding us of our own loss experiences, our own experiences for loved ones who might have experienced something similar. And it can be hard. And so because of those things, I always like to show this slide where I just say, okay, what is something we don't say? What is something is not helpful to say? And this was coming from an article that really was directed to providers. And it was like, this is what you say, this is what you don't say. And so what not to say, it is best this way. You have more time. You will have more kids later. It could be worse. Time heals all wounds. Aren't you glad that it happened at this stage and not later? All of these things are unhelpful. All these things are really can be invalidating, because if someone's in pain, even if they later on in life, they can like look back and see, make meaning of it, in this moment, they are just looking to be heard and seen. I also really encourage folks to be careful of things like I know and I understand. And even if you've seen these types of patients multiple times, you don't know the experience of the person sitting in front of you. You don't know the things they've been through, the shoes, having to walk in their shoes. Right? And even if it's not a wanted pregnancy, it can still be really devastating. So what do we say and do? I think it's really uncomfortable to be comfortable showing emotion. People want to know that there's another person sitting across from them. And so it's okay if you're feeling emotional and you're feeling like this is really hard, you can say that. Like, I can imagine how hard this is, and I'm feeling sad too, or this is really difficult as well. You listen to the story, letting folks have their time to share their story if they want to share pictures if they want to. You can apologize if that's helpful. You can even say, I don't know what to say. There are times even in therapy and working with lots of different patients, I'll say, you know what, there's nothing I can say to take away your pain, but I am here with you in it. Now, also would say encourage starting statements with, I can imagine. That's better than I know or I understand, because then it's just like, I can imagine this is hard for you. And that gives people the opportunity to be like, nope, that's not what it is, or yes, that is what it is. I think, again, normalizing their intense emotions. It's going to be an up and down roller coaster at times. It can be like one day they're feeling okay, and one day they're not. It can be also acknowledging it. Sometimes we'll avoid the loss because we don't know what to say. It's like, no, you can speak it. Because sometimes folks will be like, it's like almost taboo for folks to speak it. Again, you can offer non-judgmental support. If it's just okay to be silent for a few moments. If you don't know what to say, maybe even pausing for a few moments, letting people collect themselves and then starting again. And I think using mirroring language, if people want to say their child is in heaven, you can repeat that back to them. I think mirroring their language helps that you have a shared language of what's happening. The other thing is, how do we support ourselves? These can be the hardest cases. These can be the hardest things, especially when people are telling you the story and they're very graphic in it. They're like, this happened and this happened and this happened. It can be hard to hear. It can be hard to sit with. And secondary traumatic stress is real. So when the research looks at health professionals, nurses, doctors who are supporting these patients, they found that there's high risk for secondary traumatic stress, for burnout, that our own emotional responses as the helpers can be self-doubt, can be feeling like we failed the patient, feeling guilt, we can feel frustrated. Some folks will also emotionally distance themselves, but kind of like, okay, I got to put a wall up because this is too hard. And then it can start this vicious cycle where this trauma occurs. The providers, to protect themselves and to cope, they just take a step back. Emotional detachment is a symptom of secondary traumatic stress. And then they respond to patients in a cold and sterile manner, right? And then patients feel invalidated. So a lot of times when they say that when looking at secondary traumatic stress, it literally leads to poorer patient outcomes. And so one of the things that when we think about what are the symptoms of secondary traumatic stress, these are the symptoms of PTSD. These are intrusive symptoms. These are nightmares, intrusive memories, intrusive thoughts of harm coming to themselves or loved ones. It could be numbness. They can feel detached. They can feel just kind of out of it, guilt, empty, depressed, or hopeless. They can have difficulty concentrating or focusing. It's hard for me to do notes. It's hard for me to chart. It's hard for me to talk with patients. I'm zoning out when patients are talking. It can be avoidance. I can't go back to the unit where this loss occurred. It's hard to walk past them. And all these things of like our own trauma, right? And our empathy, right? What makes us susceptible to secondary traumatic stress is we care. We care about these patients. You care about your patients or you wouldn't have shown up today. And all of those things make us more likely that it can be really impactful. And it's not only just one loss, it's like that cumulative effect. When you have patient after patient after patient who are going through this, it can take a toll on us. So how do you manage this? One way is education. That's one of the biggest ways of helping folks manage this. And so check box, we've been educated today. Not only on secondary trauma, but perinatal loss. It's also self-care. Whenever I talk about self-care, I'm not talking about eating, sleeping, and moving your body. That's what makes you a functional human. I'm talking about intentional things that bring you meaning and value into your daily lives. It's also feeling like that your work is meaningful, like feeling like I'm making an impact, feeling I'm making a difference is important. And that's a good buffer to secondary traumatic stress. It's feeling like my team is supportive, that we're not just going through the patients and keeping it moving. We have spaces and times to talk about how hard it is at times. And it's sometimes it's psychotherapy, sometimes it's coming into therapy. I not only see patients, I also see sometimes providers who are having a tough time grappling with these issues. So again, like they have these like different programs to help folks to reduce secondary trauma. And again, that's feeling like I'm living with integrity, I'm working with integrity, I feel supported at the system level and at the team level, even in a personal level, right? And so as we're coming to a close, so I'll make sure I have time for questions, is I always ask, like, what emotions are coming up for y'all as we talk about this? We all have our own experiences, our own fertility, childcare journeys, and some of these things can be coming up even as we talk about it, right? Caring for others will oftentimes bring up our own grief experiences. There's been times where I talk to a patient, I'm like, woo, your story seems a little too close to mine. And it's hard. And it's like, that's when you have to think about, how do I take care of myself? How do I get my social support system involved in taking care of me? And as we're just kind of ending this like kind of talk, I love this quote of compassionate people ask for what they need. They say no when they need to. They say yes when they mean it. And they're compassionate because their boundaries keep out resentment. So I want to leave time for questions. There are definitely some resources that I can share this with you all, of different resources and groups you can give patients, as well as resources for providers if they're just kind of having a patient and don't know where to go. And then we can just kind of open it up to questions. And I'll stop the share so I can see y'all faces as we talk. And I do have some vignettes if that's helpful to kind of guide the questions and answer, but just let me know what's most helpful.
Thank you so much, Dr. Johnson. We appreciate your sharing, and maybe we can open it up first for the conversations for any questions that are within the group, and then maybe bring back the vignettes after if we have any questions in chat, or come off mute.
Okay. Will we have access to these slides? I could definitely send you like a PDF copy of some of my slides with some of the information. I can also send you my, if you're interested in like where I got some of the data and want to look at that, I could also send you my reference list as well.
Thank you. Well, maybe if we start with a vignette and then come back to questions.
Okay, there's a couple more new messages. Okay, perfect. All right, so let me share again. Oh, wait, I shared the wrong screen. Okay, hold on. Sorry. Okay, seeing the right screen now?
Yes.
Okay. So, okay. So we think about a vignette. All right, and I'll let everybody read it, but I'll read it out loud. So a 33-year-old married African-American woman is seeking treatment for reoccurring pregnancy loss. She is looking for you for answers, since her infertility is unexplained as she tries to conceive her next child. She also mentioned she's hesitant to trust providers after experiencing a traumatic birth the first time. And she becomes tearful and distraught during the visit. How might you address her concerns? What might you say? What might you not say? So I'll just like say, if folks want to be brave, they want to unmute, you can unmute. If you just want to throw it in the chat, throw it in the chat.
I think personally, the first thing you need to do is ask her to tell you what was traumatic about the experience, so that one, you don't repeat it, but two, you can understand and maybe help soothe some of the trauma that happened with previous.
Yeah. I think that with trauma, I think it's going to be, I would always encourage that we don't want to open up something we can't close in like a 15-20 minute interaction. But I do think you can be like, hey, what were the particular things that you wish providers would have done differently? And I think that can lead you that conversation to be like, okay, sometimes I had patients come in and be like, y'all don't listen, y'all being the system. And so I was like, okay, so that cued me to be like, okay, I'm just going to listen. And then when it's my turn to talk, it's my turn to talk, but I want to listen more than I speak. So I agree, like really trying to understand, okay, what can I as your provider right now in the room with you do to start helping build back that trust?
And I think maybe even summarizing what is the biggest concern or the biggest two concerns, because sometimes it could be multiple things that they have concern. And so just narrowing it down, maybe the two biggest concerns, maybe during your prenatal care. That way they don't travel off into like maybe the postpartum experience or et cetera. So you can focus in on those.
Yeah. The person said, I'm sorry in the chat. That goes a long way. I am so sorry you went through that. That sounds awful. Like sometimes just being that human in that moment could go so far. Yup. Make sure you sit down. Like, I know for myself, sometimes it's hard to be like, you're trying to like do stuff, you're on the computer, but like, I'm looking at you, I see you, go so far. Yeah. Yeah. Allow them to be there. People need a glass of water. Sometimes people just like, can I get some water? They need a tissue, all those things as well. Yes. And help her advocate. So thinking about this next journey, be like, okay, so what are things, sometimes I'll be like straight up, do you take notes during your appointments? Do you write down your questions to make sure your questions get answered? Sometimes it's helping coaching folks exactly, how do I advocate for help? How do I make sure my questions are answered? Yeah. Yeah. And I think the need for answers, oftentimes when people are looking for answers, they're hoping the answers will help them feel better. They usually don't, to be perfectly honest. Sometimes they do, sometimes they don't. But I think that kind of holding that, we can try to definitely help you on that journey to help you learn more about what's happening to you. Yeah. Yeah. And like a thorough assessment, really creating a plan with the patient so her voice is heard. Again, from birth trauma is oftentimes caused by no one was listening or I didn't know what was happening. So how do we collaborative care? Awesome. Okay, so the second part is this. Oops, sorry. So, okay. So what happens after the patient leaves? And you realize that this hits you hard and that maybe this was your fourth patient of the day that was really hitting you. And you're at the end of the day, you're drained, right? What is realistic self-care? Knowing that I bet you all of y'all have lots of things on your plate, lots of responsibilities, lots of whole hats and roles you're carrying. So what does self-care look like at the end of the day, especially when it's been one of those really hard, heartbreaking stories you've heard? Mm-hmm. Seeking social support, calling friends, yep. Music, long walk. Mm-hmm. Yeah. The thing about quiet reflection, someone put in a comment, I remember for a lot of providers, I asked, what is your decompress? Like, how do you transfer from one role to another? Some people will be like, I go straight from being a nurse to being mom, to being parent, to being wife, to being husband, to being all these other things. And then it's like, I have no time to process what just happened today. And I'm just taking care of people all day, right? And I think taking that time to be like, okay, what do I need to do to calm my body down, calm my nervous system down, calm myself down? Yeah.
Actually, I would say, I think the first time that we actually connected, like that was one of the things that kind of sparked for me, was realizing that there's so many times where we keep going and going and we don't stop and realize like that secondary trauma, but also thinking about what barriers we put up because that's experienced, and how does that actually show up in the work that we do every day, because we're trying to prevent something from happening again. But when you put those biases, like you start to create things in your process to prevent you from doing those things again, so you don't go through that again.
Of course, when we go through something awful and painful, we want to avoid pain. I think that's a part of the human experience. And I always tell folks that like avoiding pain is a part of the human experience. And so like, even as providers, we were trying to do a lot of things so we don't feel that pain, or we're trying to protect other people from feeling pain, right? Yeah, yeah. A good cry. Sometimes it is a good cry. So I'll throw another vignette. So this one's a different one. I didn't go into multiples, but we can kind of talk about that. Is a 28-year-old Caucasian mother prematurely births triplets after a complicated birth. She and her partner are religious and have some family support. After several weeks, two of the children pass away. You interact with these folks on a postpartum visit and they ask for support. What might you say or do to support them? Who can unmute, they can throw it in the chat, whatever helps. This one's hard. What can I do to help? What can I do to help you in this moment? What type of support are you looking for? Ask about the names of the children. You'd be surprised, oftentimes be like, baby, it's like, wait, what's your name of your child? Like, tell me about them. What was happening? Yes. Connect them to postpartum support, great support. They do have great support groups. Yep. Yeah. definitely try to connect them to other parents. There are websites out there for parents of multiples as well. Yeah. I think the hard part about parents of multiples, especially when it's premature birth, we know that it's a lot more likely to have premature birth and complications with multiples, is that when one of the multiples die, then the parents are having simultaneous joy for their one child and sadness and depression for the child they lost. That can be really upsetting and hard to grapple with. And sometimes I do in session is holding space for both. It's okay to feel both. It's okay to feel joy and happiness that you have this one child in the world. And it's really okay to feel sadness and despair that you lost two others. Yeah, that you can hold two opposing emotions at the same time. Yeah. So what happens though? Oh, another curveball, y'all. What happens if your clinic is slammed? You are behind. I know everyone has that experience with you are behind on patients. You're trying to get from one thing to the other, and then this happens. How do you support folks? How do you support folks? How do you connect with your other team members? How do y'all relay that, knowing that, you know, that sometimes it happens in healthcare where we're like trying to move and do a lot of things at once? Anybody can answer. Make clear plan for follow-up, yeah. Being present, like just because, like even if I'm gonna be late, yep. Yeah. Encouraging them to speak. Yeah. It might also be relaying to the other people in the clinic and your other team being like, hey, I have a patient I need to just sit with. We gotta be present with them and being like, okay, can you go grab so-and-so? Can we tag team and help us keep moving forward so we're there for the other patients that we have to take care of, but I can be present with this patient.
I think this was from the fourth trimester, thinking about postpartum loss and or loss in the postpartum period, and you're returning back. Some of the things we heard was like having to go back to the doctor's office after having that loss and the care that's needed to support, and just how practices have uniquely set things up to support individuals. I know one practice has actually created like a side door where you, if you've had a loss, you can either come in that door and go out that door, so you don't actually have to see other individuals that are pregnant, to help you process that. And then also thinking about when you're scheduling the like appointments and how do you have those conversations, especially when it's in a busy clinic, or if you're also in a if you're on the unit, like how do you help to navigate those parts?
Yeah. Yeah. And it is like I usually have a conversation with folks being like, hey, just so you know, my office, I don't know if y'all know, my office is on top of a maternal fetal medicine office, and I'm like 2 floors above it. And so to get to my office, you got to go past the perinatal office downstairs. And so I'll be like straight up with folks, like, if you want to come in person, just know this is this. How do you want to manage this? I can meet you at the elevator. We can walk up the stairs. How do we know, how are we going to manage this? And letting, you know, patients, some parents are like, no, I'm cool. That's fine. That's okay for me. And other people are like, yes, I do want a different way. And some patients will like kind of gradually expose themselves to be like the beginning is like, no, I needed a separate way. And now I actually, as I'm healing, as I'm working through, I'm able to go past it. So I think that kind of having that conversation with folks is helpful. Okay.
Thank you for sharing. I know one of the projects that we actually started our conversation with you was actually, it's the Supportive Birth Services Project that we've been working with one of the hospitals within our region. And they've actually taken, they created kind of a process for individuals that have had trauma, a traumatic birth experience or a loss, and they actually go through the process. And what they've done is their team has taken different educational sessions to help for them, their training to know exactly what to say to individuals that have had loss, how to not fix things. Because I know as I usually try to fix things because that's what nurses do, we fix things. But being able to have the resources and having those conversations has been something that the nurses have said has been helpful, but then also identifying trauma experiences too within themselves and how they didn't realize how it impacted them too.
It brings up stuff when you dealing with other people's trauma, it kicks up the stuff maybe you thought was buried or maybe you thought you worked through, and you're like, oh, I did not. And so now how do I manage that? Yeah.
Yeah. Any other, do we have any questions? Any other questions for Dr. Johnson? And I would like to share a note. Xavier Bell is actually an individual that's actually written a book related on perinatal loss. And I was trying to find a link, but if we can't find the exact link, we can drop it in later. But it's the morning after, and she talks about her experiences after having a loss at 20 weeks and having conversations. And she's actually come back and presented with UNC's the School of Medicine and the residents, and talking about like how all these things are important, like knowing what to say and how to say it and when to say it. And what that loss meant to her and how she had to navigate grief and how the team had to work. So that might be another interesting read for people to kind of see. Yeah. Awesome. Well, thank you for your time and for being here. I don't see any other questions in chat today, unless there are more questions, or if anybody wants to come up, you please feel free to do so. Awesome. For those of you that would like to receive nursing contact hours, Rachel's dropped the link in there to complete the evaluation, to receive your contact hour. If you have any questions or you're not able to get that, you can feel free to reach out to Rachel to get that information. And I see Sarah back on. Do we turn over to you?
Thank you. I have just so many thoughts, and I really appreciate this, not only professionally, but personally, having just been through a miscarriage trauma with a really good friend, and having stood there while people said the things not to say, and also understanding it is a very complicated space, way more than I understood until you, and so I appreciate you so much, and also honor everyone that works in this really special field of medicine. So thank you so much. So I think, Suzanne, did we have any final info or update slides? Or any share from MHI or projects?
Sure. So the big update we have is that we have some exciting new video reels and content that's coming out. We are working with DPH to make sure that everything's in the warehouse, and we've expanded tools and adapted to have even more tools. So the big heads up is just to be sure that you're on our subscribe list. If you're not, you can go ahead and put your email in the chat and I can go ahead and add you. Please do submit an evaluation for this today, and then check the chat for information about nurse contact hours. And then we will have some announcements, like I said, about there's an upcoming postpartum toolkit video, some new tools, and some new resources for our MHI and for our postpartum care providers. And then in those announcements, you'll also hear about our upcoming communities of practice, because the August date we have it set, but we'll announce that in the coming weeks.
Awesome. I wanted to let everyone know that we are getting ready to start sending out emails to health departments. So we're ready to start providing some TA and technical assistance a little bit more broadly. And we are able to do this because we've had Rachel Yip join our team. I don't know if we formally introduced Rachel yet, but Rachel is a nurse educator, and is available to help us expand our outreach. So there's Rachel. So we're really excited to have her on the team, and excited to be able to expand our outreach coming up. And we are also working on a treat for a grand finale webinar in September. So details coming soon. And I think that's all we have. So I hope everyone can use your extra 7 minutes to do what Dr. Johnson suggested and take care of yourself, because this is also big content that likely also brought up things for everybody. So look to those comforting rainy day activities you mentioned earlier. Take a beat to take care of yourself. And we look forward to being back in community with you again. And thank you again, Dr. Johnson. I'm so glad that we get to work with you and that we have your gifts in this world. Thank you.
Thank you for all that y'all do. Like that's why I always like to end with like how we take care of ourselves, because this is hard work, this is good work, and I'm so glad y'all
everybody.
Thank you so much. All right, everyone, have a good week.